Hi, everybody. My name is Nishtha Sareen, and I welcome you to our podcast for BIA, for you, for them, which focuses on heart conditions that affect us, and we just don't talk about it as much. We have physician experts who come talk to us and give their insight on it. It is my pleasure to welcome Dr. Emily Lau, who is Women's Cardiovascular Health Specialist and Investigator at Mass General Brigham. She is the co-director of Mass General Brigham Women's Heart Health Program. Dr. Lau leads a clinical-translational research program that focuses on imaging, exercise physiology, data sciences, looking at electronic health records, patient-oriented studies, has a lot of experience with support from NIH, American Heart Association, Massachusetts Life Science Center, and the Tianqiao Chrissy Chen Institute. Dr. Lau, it's an honor to have you here today. Thank you. And Dr. Lau, with her expertise, is going to talk with us about hormone replacement therapy and heart attack risk today. As we're aware, that there has been a lot of controversy over years at this topic, and it helps women who have symptoms of menopause, which would be hot flashes, night sweats, not being able to sleep as well, also with bone health. But then there were some questions and concerns about it increasing the risk of stroke, heart attack, blood clots. And now more recently, with the data that we are seeing, the FDA has removed a lot of those black box warnings. So Dr. Lau, please tell us a little bit about who are the patients who are eligible in 2026 and should be looking at hormone replacement therapy.
Well, first off, thank you so much, Dr. Sareen, for inviting me onto this podcast. I'm so thrilled that we are spotlighting such an important topic that has for so long gone overlooked and under-discussed, and that's the relationship between menopause and cardiovascular disease. And there really is no better time to be talking about menopausal hormone therapy and cardiovascular effects of this important therapy. As you alluded to, there have been a number of changes, in terms of FDA guidance on who are the right patients to be taking hormone therapy. And just to be explicit, so what Dr. Sareen is referring to is that just late in 2025, the FDA removed all boxed warnings on estrogen-based menopausal hormone therapy products. So this includes systemic hormone therapy formulations, including oral estrogen, as well as transdermal estrogen, as well as, local vaginal estrogen formulations. And this was really a very important landmark decision that was made by the FDA, and it certainly it does not come without controversy. I would say that there has been a lot of confusion about the cardiovascular effects of menopausal hormone therapy, and patients are completely validated in saying, well, who is the right person who should be taking menopausal hormone therapy? Where are the data? I'm so confused. And that's really because the data are very confusing. I think at this point, just to answer your first question is, who is the right person to take menopausal hormone therapy in 2026? The current FDA guidance is that menopausal hormone therapy is indicated for treatment of menopause-related symptoms like vasomotor symptoms, which include hot flashes and night sweats, prevention of bone loss related to menopause-related bone loss, treatment of vulvovaginal atrophy, and finally, in patients with premature ovarian insufficiency or premature hypoestrogenism. You'll notice that I did not mention prevention of cardiovascular disease as one of the 4 FDA-approved indications for menopausal hormone therapy. And this is critically important because there's a lot of confusion about this. And that's because a long time ago, many decades earlier, we as a medical community really thought that treating women with menopausal hormone therapy with estrogen replacement would in fact be an important preventive strategy for the development of cardiovascular disease. But as we'll review later in this podcast, the data have shown us and currently do not support the use of menopausal hormone therapy for for prevention of cardiovascular disease. So how do I put that in context with the recent FDA label change? I would say that as a community, we all applaud the FDA for making these important changes, particularly with respect to vaginal estrogen, the locally absorbed estrogen. However, removal of really broad black boxed warnings for the systemic formulations, including oral and transdermal formulations, I think is probably worth some reexamination. There are some patients for whom oral hormone therapy is absolutely appropriate, but there are many patients for whom it is not the appropriate treatment. And so I think as a community, certainly in the cardiovascular community, in the menopause community, we have a little bit more reticence with the removal of the broad boxed warnings with respect to the oral and transdermal systemic formulations of menopausal hormone therapy.
Thank you, Dr. Lau. That was beautifully explained. If you want to tell us a little bit also about the timing, because a lot of times it is whether it started within 5 years or 10 years of the onset of symptoms, and maybe that's something that's also really important when it comes to CV protection.
So you're absolutely right that actually the perimenopause is an important period of time, and we actually see that many symptoms of menopause really occur prior to the onset of the menopause transition. And so if a patient is actually in this perimenopause period or actually sort of transitioning through menopause and have very significant menopause-related symptoms and have a good cardiovascular risk profile and do not meet the strict contraindications to menopausal hormone therapy, they may be a very good candidate for hormone therapy. But again, we would not use hormone therapy as a prevention strategy for cardiovascular disease.
Absolutely. And what about estrogen versus estrogen progesterone combination? Which of those, and how do you decide, which one is the right one for the patient? I'm sure it's individualized for the most part, but what's your take on that?
Well, actually, the addition of progestogen is a very simple one. If a woman has an intact uterus, meaning they have not had a hysterectomy, if they are going to be on estrogen-based hormone therapy, they absolutely must also be on concomitant progesterone therapy, and that's for endometrial protection. It's only in women who have had a hysterectomy or have undergone a hysterectomy for whom they can take estrogen-only based hormone therapy.
Thank you, Dr. Lau. Please give us any final words of key take-home points that you think are really important when it comes to hormone replacement therapy in 2020.
I think the three big takeaways is first that menopause happens to every woman, and the menopause transition is a normal part of aging, physiologic aging, but that doesn't mean that women need to suffer. So, for example, if they experience significant menopause-related vasomotor symptoms like hot flashes and night sweats, there are treatments, both hormonal and non-hormonal treatments for these symptoms. My second big takeaway is that menopause actually represents a time of accelerating cardiovascular disease risk. So this is an important time for us to prioritize cardiovascular preventive strategies, including optimizing LDL cholesterol, blood pressure, weight, diet, exercise, all of the above. I think oftentimes women in their midlives their cardiovascular risk is underestimated because they're relatively young. But actually, this is a critical time to be making sure that cardiometabolic health is fully optimized. And finally, I would say that it is completely understandable that why we are also confused about the literature related to menopausal hormone therapy. And so if you are a patient or a provider who is taking care of patients in their midlife, and there's a question related to menopausal hormone therapy, and particularly its effects on the cardiovascular system, please reach out. The data the pendulum really has swung back and forth throughout the years. And so it really is confusing. And also we don't have all the available data yet. So This is an active area. A lot is changing. It's very dynamic. We need more research in the field. But please don't feel like you have to, as a patient, go through this transition alone, and certainly as a provider, manage patients in midlife alone.
Thank you. I couldn't have imagined anybody do a better job at this, Emily. Thank you for taking the time. Dr. Lau, it was our honor to have you today. Please put in any questions. If you have any future suggestions about the topics you want covered, please send us an email on viayourselfcontact@gmail.com. At this time, I'd like to thank Dr. Lau for taking the time, sharing her expertise, and we will see you next time. Thank you and have a good evening.
Thank you so much.